You're listening to Conferences Online Allergy from Children's Mercy Hospital in Kansas City, Missouri. Today is September 8th, 2023. Our topic is mast cells disorders, presented by Dr. Mariana Castells. She is the director of the Mastocytosis Center and of Drug and Hypersensitivity and Desensitizations at Brigham and Women's Hospital. She is also a professor of medicine at Harvard Medical School in Boston, Massachusetts.
Good morning. You're listening to Conferences in Online Allergy from Children's Mercy Hospital in Kansas City, Missouri. Today is Friday, September 8th, 2023, and today we have Dr. Mariana Castells, who's going to speak to us today about mast cell disorders. She's the editor-in-chief of Current Allergy and Asthma Reports, director of the Drug Hypersensitivity and Desensitization Center, and director of the Mastocytosis Center at Brigham and Women's Hospital, and professor of medicine at Harvard Medical School. Thank you for being here today.
Thank you so much for inviting me. It is a pleasure for me to talk to you today about mast cell disorders and to potentially amplify kind of the universe of the patients that you are actually seeing and seeing how can we best address what their symptoms are and what their disease is, the final diagnosis is. So let's start with my learning objectives. I would like you to understand further the scope of what we call clonal and non-clonal mast cell disorders to address how the presentation of those disease and the associated underlying mechanisms, what we call the endotypes, and then kind of the role of the KIT mutations, the TPS-AB1 genotyping in the diagnosis of mast cell disorders, which is like a new kid in the block, and then to review some of the management for mast cell activation disorders and the future options for those patients. I want to start with a dramatic case of a 4-month-old boy with fever, viral disease, and who started at home with skin blistering to the parents extremely disconcerted about what was happening to the kid. He had a seizure. He was admitted to the hospital and was placed on vancomycin, and he had a cardiac arrest. And his skin looked like tremendous blisters. And he was treated appropriately. And at the end of the day, what we wanted to show in this kid is that one of the things that cannot be missed in children is what we call diffuse cutaneous mastocytosis. So the kid had a peau d'orange that every time we scratched that, we had a tremendous wheel and flare reaction that we called the diarrhea sign. And when a biopsy was done of his skin, we saw that he had a plethora of tryptase positive cells, and his tryptase level in the peripheral blood was 164. So again, it's a case not to be missed for a kid who actually had a kind of a sign of a mast cell disorder, the diarrhea sign. Nobody paid attention, and the kid didn't die. The kid made it. But again, he had also was found to have another KIT mutation that is associated with tuberous sclerosis, but the presentation was extremely dramatic and very similar to a lot of the children who present with diffuse cutaneous mastocytosis. So for all of us, pediatricians, internal medicine doctors, we cannot miss that presentation. So in terms of what we understand about mast cell disorders is there is a huge component, as seen here in blue, of activation symptoms, and there is very little of proliferation. So mast cell activation disorders, in the majority, are disorders in which we will find symptoms of mast cell activation, which we will talk in a great detail. And there is a little bit of proliferation, particularly in the clonal disorders. So what we have, what we call the primary mast cell activation disorders are mastocytosis, whether systemic or cutaneous, monoclonal mast cell activation syndrome. And in those disorders, we have a KIT mutation in over 95 to 99% of the cases. And we also have a very critically important thing, which is that the mast cells are activated by the expression of what we call CD25. So we find mast cells in every organ, whether in the bone marrow, in the gastrointestinal tract, or in the skin of those patients, and those mast cells express an activation marker due to their clonality. So that makes a diagnostic criteria. In the secondary mast cell activation disorders, we have symptoms that fulfill potentially the criteria of mast cell activation, but do not have any mutation and any clonality. And as I was mentioning at the beginning, hereditary alpha tryptasemia is being in between all those disorders. And idiopathic mast cell activation disorder, we will not have a secondary diagnosis. So the modern view of that is based on the kind of new classification we have here, which is that we have criteria, and we will talk about what's the criteria that fulfill mast cell activation disorders, and we have this clonal, monoclonal, we have a secondary, and we have idiopathic diseases, and we have that secondary, which is other diseases, connective tissue disorders, asthma, allergic rhinitis, any of the atopic disorders. So when we see here the kind of the most recent classification, we have that in the primary mast cell activation disorders, we have to have a KIT mutation that is detected, or the aberrant display of that CD25 in almost all cases. And there has to be a confirmation that the patient has either mastocytosis or either systemic or cutaneous. And then there is at least two minor criteria. In the secondary mast cell activation disorders, we have symptoms compatible with mast cell activation, but there is no neoplastic mast cells, there's no mutation, there is no CD25 expression, and the patients have an underlying diagnosis that is likely the trigger for their secondary mast cell activation. As I was indicating, atopic disorders, asthma, allergic rhinitis, urticaria, many others, thyroid disease, other connective tissue disorders. Then we have the hereditary alpha tryptasemia, which, as I was mentioning, is the new kid on the block, which can have symptoms of mast cell activation. But just remember that it's a genetic trait located in chromosome 16, and that people who have this trait, the majority of them do not have symptoms. So most of the time, what happens in people who have hereditary alpha tryptasemia, they have an ongoing mast cell activation for some other potential reason. And the fact that they have this duplication of the tryptase gene makes them more susceptible for anaphylaxis and more severe events. There are a mixed form of mast cell activation disorders, as we were saying, and then you have the idiopathic form. So the classification has kind of more recently been refined. And as I was mentioning here, we have that in the clonal diseases, or we have increased mast cell numbers. In the activation diseases, we have an activation excess. And mast cells can be activated through what we are seeing here, the Ig receptor KIT with a mutation, complement the anaphylotoxins, the complement receptors, MRGPRX2, IgG. So mast cells release mediators such as heparin, such as histamine, such as tryptase, platelet activating factor, leukotrienes, prostaglandins, cytokines. So the symptoms of mast cell activation syndromes are due to the release of those mediators and the impact of those mediators in the tissues. Let's start from clonal diseases, and I will actually be presenting to you cases, clinical cases for kind of illustrate what I just mentioned to you. This is a young woman with her daughter. She is lying unconscious in the bathroom, a pool of blood, and she's feeling hot and dizzy and has a fluttering heart. And she went to the emergency room and was told that those kind of the rash that she had in her legs and her thighs were freckles. And in fact, if you scratch those, they would have a positive diarrhea sign. So the kind of woman had cutaneous mastocytosis and likely systemic mastocytosis under diagnosed. Another presentation is Hymenoptera anaphylaxis. So when Hymenoptera, there is the venom it can activate mast cells through IgE. So there is a potential for creating an IgE against wasps, honeybees, any Hymenoptera, but there is also the possibility of activating mast cells through the venom itself, not through IgE. And the symptoms, again, are the symptoms of anaphylaxis, the hypotension, the syncope, the flushing, the hives, the angioedema, abdominal cramping, nausea, and patients have to be evaluated for potential mast cell disorder. And this is the presentation, 47-year-old who is stung by a yellow jacket in his backyard. He is positive for the yellow jacket and honeybee. He starts on immunotherapy, but continues to present symptoms of mast cell activation and, in fact, of anaphylaxis. And his tryptase is 29 during one of the episodes, but at baseline is 25. So again, because of the elevated tryptase, the patient has a bone marrow biopsy, and we have here that he has aggregates of mast cells that also stain with the KIT. So the patient has not only Hymenoptera-induced anaphylaxis and he's allergic to yellow jacket and honeybee, but he has his underlying disease is systemic mastocytosis. And one of the things that we have done here at the Brigham and Women's Mastocytosis Center is we have done ultra-rush desensitization for those patients because those patients are at high risk of anaphylaxis, and there are fatalities that have been reported in patients with a very high mast cell burden who are stung in the field and who, regardless of how many EpiPens they can inject themselves, they actually had irreversible cardiac failure and cardiovascular collapse and are dead. So we have started a program where in about 6 hours we can desensitize those patients. And you see here that we presented the first initial 9 patients. Most of them we have here indolent systemic mastocytosis. So a lot of them. And here you see that one of those patients had 4 EPIs given in the field. His tryptase was 2,600 during the event. His baseline was in the 20s, and the patient was given this ultra rush with, I think in this patient we use omalizumab, and the patient is currently in the field, has been able to get maintenance with his Hymenoptera injection and has done extremely well. Another presentation will be through a drug reaction. For example, this is a male who runs the Boston Marathon, and he has 800 milligrams of ibuprofen. He starts to be very flush, hypotension, he's short of breath, and he's intubated. His tryptase also over 2,000. And when the patient is extubated, doing well, we ask the patient if he has chronic symptoms of flushing, depression, anxiety, bone pain, chest pain, and he had multiple lesions in his chest. Nobody actually had really undressed him when he was going to the emergency room, which he had gone many times because he's a runner and he had been taking ibuprofen many times. And his bone marrow also had those aggregates of mast cells that express CD25, and he had a positive KIT-D816V mutation. So again, another presentation for a clonal mast cell disorder. And this one is kind of a more subtle one. This is a female with allergic rhinitis. She's positive for grasses, for ragweed, and she has episodes that occur during her immunotherapy injections, but also after she stops her immunotherapy injection, she continues to have those episodes, severe cramping, abdominal pain, nausea, vomiting, feeling faint, and feeling this hand and feet burning. And her blood pressure goes really low, multiple EpiPens. Tryptase is not elevated at baseline, and she's fine to have in peripheral blood a mutation. Her bone marrow disclosed this abnormal mast cells that express CD25, so spindle-shaped mast cells with CD25, and she has what we call monoclonal mast cell activation syndrome because she does only have the 2 minor criteria. And this is something that is missed in pathology a lot of times. And you ask your pathologist, oh, well, there is no aggregates. Okay, can you stand this for CD25? Because CD25 will give you the clue that those spindle-shaped mast cells, although there is no big aggregates, are abnormal mast cells that express CD25. They're spindle-shaped, and they already have 2 minor criteria. So as I was mentioning to you, we have now a kind of wider version of how mast cells can be activated. They have not only the IgE receptor, they can be activated through complement, through TLRs, through PARP receptors, through KIT, but also through MRGPRX2. And they actually release all those mediators at once. And one of the things that we have been trying to do is relate what the mast cell mediators and the symptoms of patients. So, for example, if patients have increased histamine or prostaglandins, that can lead to vasodilation, hypotension, but also mast cells have cytokines. So they release TNF-alpha, IL-1, IL-1 beta, IL-6, and that can actually lead to symptoms of fatigue, cachexia, and others. And prostaglandins also impact the skin, the flushing, and also impact what we call the mixed central nervous system syndrome, brain fog, anxiety, inability to concentrate, short memory span, sometimes being a little bit more aggressive and short-tempered. So all of those things can actually be tracked by mast cell mediators. The classification that we have for the clonal mast cell disorders are, as I mentioned before, cutaneous and systemic. And the systemic, the predominant form is the indolent form, and then there is an associated with hematological malignancy and aggressive form, mast cell leukemia, and then mast cell sarcoma and extracutaneous mastocytosis. But the criteria is well known to you potentially and to pathologists: more than 15 mast cells in aggregate, CD25 expression, the KIT mutation, and then the abnormal aberrant mast cells, as well as the tryptase over 20. So this is well accepted criteria. So missing systemic mastocytosis is difficult, but as I presented to you, somebody of an adult age who presents with urticaria pigmentosa, the likelihood they have mastocytosis is over 80 to 90%. And mast cells can be found in the gastrointestinal tract. So for people who have gastrointestinal symptoms and do not want to have a bone marrow biopsy, that is possible to have a GI biopsies, and those biopsies can actually illustrate the same thing, and the criteria applies here. So there's 15 or more aggregates of mast cells, CD25 expression, KIT expression, and tryptase expression. For the patients that we are seeing who have mast cell activation disorders that are non-clonal, this is helpful because you see here that in the duodenum, they can be 50 or 51 mast cells, and we consider that to be normal. There can be 31 mast cells, and that can be normal. In the colon, in the stomach, it can be 20 mast cells. So again, the numbers, because they are not aggregated, can be high of mast cells, whether the patient had a gastrointestinal infection, patients have had inflammatory bowel disease or symptoms, and those mast cells can actually increase, but it does not provide criteria for systemic mastocytosis. The mutation that is most important is in here, the D816V. One of the things that a lot of people have been asking is, how about a patient who I diagnose with mastocytosis? How do I follow that patient, and how do I make sure that the patient doesn't progress to have a more aggressive or a hematological malignancy? And you can do the detection of the KIT mutation now is done, what we call the allele burden can be done in specialized laboratories, and increasing the allele burden is what makes the mast cell progress, the disease progress. So patients who have about 1 to 2% of allele burden in the peripheral blood are unlikely to progress to any further more advanced disease. And that is also seen here, in which you see the different patterns of KIT mutation. Here, only the mast cells have the D816V mutation. Here, all the other lineages have that mutation. And the likelihood in those patients that they progress into more aggressive and advanced disease is very high. And one of the things that's important is in patients with systemic mastocytosis, about 10% to 15% will have normal tryptase. So we'll have to rely on other criteria to make a diagnosis. And in anaphylaxis and mast cell activation disorders, what's important is to be able to capture the tryptase during the event, but also to capture the tryptase at baseline. And this is what the presentation for patients are. In the diffuse cutaneous, we just have to scratch that skin and be able to elicit a diarrhea sign. In children, the prognosis of the children, although it looks pretty severe as in this picture, those children by puberty will have their disease will disappear completely. The presence of this monomorphic versus the polymorphic is what makes a diagnosis of systemic mastocytosis more likely. Adults with this monomorphic form, over 90 to 95% will have systemic mastocytosis. And this is the cutaneous mastocytoma, again, that you can scratch the skin and be able to see that. And the diarrhea sign is something that no fellow or no resident should not be able to do that. You can do that with your finger, you can do that with the scratcher, and there is a flare, a typical William flare reaction that is pathognomonic and diagnostic of a mastocytoma or cutaneous mastocytosis. In some patients with cutaneous mastocytosis who had gone for a long time, the lesions are no longer red, they are brown, and it's harder to elicit a diarrhea sign, and the diarrhea sign may not be able to be done. As I mentioned, the kind of the more frequent mutation is the D816V, and in children with cutaneous mastocytosis, it's a temporary disease. An important point that I want to make here is that less than 10% of children with cutaneous mastocytosis have anaphylaxis. So if the kids do not have food allergies, drug allergies, or any trigger for potential anaphylaxis, most of the time, and a normal tryptase, most of the time we do not provide EpiPens to those children because the course of the disease is extremely benign. And educating the family, the school, the environment for the use of the EpiPen may not be necessary in those children. So normal tryptase, never had an anaphylactic event, we don't need that EpiPen anymore. In adults, it's not the case. 50% of adults or more will have anaphylactic events when they have a clonal disease, and they need to carry not one but two EpiPens. And the disease is not temporary but chronic. So going back to this, we have seen now primary diseases. Let's talk a little bit about the secondary and the idiopathic there, but also, for example, this in systemic mastocytosis, we have the patient who has severe osteoporosis and has a fracture, that if we go deep in the history, the patient had diarrhea, inability to concentrate, mental fogginess, flushing, and provoke anaphylaxis. So again, in a patient that is seen by the endocrinologist, and the endocrinologist is saying, hey, I have this 30-year-old male who has pretty bad osteoporosis. We need biphosphonates or some more severe. I just got a tryptase and it's 60. What should I do? And you come in and you say, we have to evaluate this patient for systemic mastocytosis. And again, this patient was a patient of our who came to our center with exactly this presentation. And we told the patient that all the symptoms that he had for the last 20 years were due to his systemic mastocytosis. This is another case where we have since age 12, a 22-year-old male with allergies, anaphylaxis, and flushing. He cannot get a steady job because his heart rate is dizziness and has presyncope, and he's actually a musician who named a song Tryptase, and he has small fiber neuropathy, this orthostatic cerebral hypoperfusion syndrome, and he has family members with similar symptoms, POTS-like symptoms. He has a tail test that's positive. His tryptase is like a 18, and he is also positive for wheat, for peanut, for scallops, and it has negative KIT mutation, bone marrow negative. He has hereditary alpha-tryptasemia with this secondary mast cell activation syndrome, and his genotype is 3-alpha-2-beta. So this kid was a genotype for that. And we are familiar now with this duplication or triplication of chromosome 16. A piece of that chromosome is triplicated, and it's TPS-AB1, and it is actually, as you see here in pedigrees, at least in 2 to 3 generations. And whether the all the members who have hereditary alpha-tryptasemia have symptoms has not been well defined. But again, we are seeing the proband, and then the proband has several members, and some of them do have symptoms. And the symptoms are not classical symptoms of mast cell activation. Those patients may have body pains, sleep disruptions. They also have some skeletal abnormalities. They have a lot of GI symptoms with the reflux and others. They have anaphylaxis, which is the most important thing, flushing, pruritus, and they have some hypermobility like Ehlers-Danlos symptoms and some POTS-like symptoms. So again, a complex syndrome that is associated with that duplication. And it's also associated with severe anaphylaxis. And like I said, 4 to 6% of the general population, but it is overrepresented in idiopathic anaphylaxis, in mastocytosis, in Hymenoptera venom anaphylaxis. What is the magic number? So the magic number is kind of changing as we go, but we have 8 as the magic number at the present time. So any of your patients whose tryptase at baseline, not during the event, but at baseline is 8, is likely to have hereditary alpha-tryptasemia, which would be nice to know. And a lot of times I get that question because that can explain a lot of symptoms. We have always tried to validate patient symptoms, and the having the hereditary alpha-tryptasemia validates some of the symptoms that I just mentioned to you, in addition to symptoms of mast cell activation. So the cost of doing this is not yet, I think, in insurance companies, but it's $169 through Gene by Gene, and we have a contract with them a little bit cheaper. So if you are in a bind and need a patient of yours to be genotype, we can help with that. And what we have seen is that the most common genotypes, 2-alpha-3-beta or 3-alpha-2-beta. This is kind of the most common, but there are 6 genes and more, and the tryptase levels are really in the range of mastocytosis. So any of those patients, because of the tryptase above 20, needs to be evaluated for KIT mutation. And if there's any doubt, the patient may need a bone marrow biopsy, but not all the cases. And we are doing much less bone marrow biopsies in patients who have negative mutations because they're positive for TPS-AB1 duplication, and we know now that those patients are not at risk for systemic mastocytosis. The symptoms that they present, again, anaphylaxis is very high, but they have a lot of gastrointestinal symptoms. Cutaneous psychiatric symptoms are tremendous, also neuromuscular, pain, cardiovascular, POTS-like, and hypermobility. And we use a variety of H1, H2, sodium cromolyn. They carry epinephrine. Omalizumab has been tremendously helpful for a lot of those patients who have, in addition, some ongoing food and environmental allergies, and that has actually prevented most, if not all, anaphylactic events. So we have a program where those patients are really evaluated for the potential for omalizumab, and those are the patients that we presented, and they have been doing extremely well. In the bone marrow of patients with hereditary alpha-tryptasemia, we did a study with our pathologist. We found that there are not, big aggregates of mast cells, but there are small aggregates of mast cells. So this is like a bone marrow with, all those tremendous aggregates in systemic mastocytosis. And this is hereditary alpha-tryptasemia, where we see those kind of spindle shape, a little bit of like a small aggregates. So again, having more tryptase genes also seems to actually implicate that the mast cells have a lower threshold for getting aggregated and potentially for activating. They do not express CD25, as you may want to know. Here is another presentation. This is a female. She has also a lot of sensitivities, odors, smells, tobacco, lotions. She has flushing. She has abdominal bloating. She has pain. She has throat tightening. But she's very functional despite all of that. She's in the tennis school team and does very well. She is on allergy immunotherapy because she has had seasonal allergies. Her tryptase is not high, but her prostaglandins are very elevated, and her KIT mutation is negative. So this is what we call idiopathic mast cell activation syndrome. And this is a presentation that we see very commonly where patients have mostly gastrointestinal symptoms, flushing, also headaches, also poor concentration, so neuropsychiatric symptoms, and have anaphylaxis in a majority. But the interesting thing here is that those patients are mostly females, and we have an ongoing kind of interest in finding, is this due to an increase in inflammasome because of the cyclical nature of hormone changes, or is it that mast cells in females are a little bit different, more susceptible to changes with the environment? And so there is some basic data that I can review for you if you're interested, that points out that the mast cells of females are slightly different, and the cues that they receive are taken in a different way than males due to this, again, cyclical inflammasome. So those patients have had, drug allergies also. They have environmental allergies. They have had a lot of GI procedures, and they are in reproductive years. Now, in terms of what you should be measuring in patients when we are dealing with mast cell activation disorders, we have a methylhistamine, which is extremely helpful. And you see here that it's elevated in the urinary patients with mast cell activation syndromes, whether clonal or non-clonal. It's also very important to measure prostaglandins, and that is also in a 24-hour urine in patients with clonal and non-clonal mast cell activation disorders. So essentially, urinary mediators, in addition to tryptase, are extremely helpful for a couple of reasons. One is to make a diagnosis. So those urinary mediators are elevated at the time of the events, and there is a kind of differentiation of those. In some patients, prostaglandins are elevated. In some others, histamine is elevated. Not in everybody, histamine and prostaglandins are elevated. And then there is another mediator, which is really interesting to us, which is the leukotrienes. So leukotrienes are extremely elevated in patients with mast cell activation also. And although there is no a specific assay that will be able to kind of differentiate them, measuring the LTE4 in the urine is sufficient to understand if the patients have elevated at the time of the events, and it goes back to normal when they are not having those events. So again, extremely helpful mediators in the urine. The symptoms that we see in those patients, like I was mentioning to you, the flushing is kind of the more important event. There is itching, there is hives, there are rashes, there is also dermatographism in those patients. Gastrointestinal symptoms are a big kind of part of the mast cell activation symptoms, and abdominal pain, bloating, diarrhea, nausea, reflux. It's present in almost 100% of the patients. Some respiratory symptoms are also present, some coughing, chest tightness, some shortness of breath, and then skeletal symptoms have a 50% expression in patients with mast cell activation. There is bone pain at times, and the neuropsychiatric symptoms are also something that we have been paying a lot of attention lately, whether it's headaches, poor concentration, memory loss, the anxiety, the depression, in some patients, this brain fog, which englobes this inability to concentrate and the short memory span. So I think, that all your patients who present with mast cell activation syndromes need to be evaluated by neuropsychiatry to actually make a diagnosis, because we're missing the piece that is due to the neuropsychiatric symptoms. And again, there are mediators that have been attributed to those, such that prostaglandins and histamine in the brain are able to induce all those symptoms. So it is important that the patients be validated in that regard, so that it's not our job to make a neuropsychiatric diagnosis, but it's our job to tell the patient or refer the patient to a specialist who will be able to evaluate where are those neuropsychiatric symptoms going. And constitutional symptoms are also a big part of the picture. For example, the fatigue and in some patients is overwhelming, and that applies to both mastocytosis and clonal and non-clonal mast cell activation disorders. As I was mentioning at the beginning, there are some cytokines that have been attributed to that, TNF-alpha, IL-1 beta, IL-6. So again, we are trying to kind of put a name to what the fatigue is in terms of the symptoms complex. One of the important things that I was mentioning is that we have been studying patients with what do you see here, MCAS, that is idiopathic or hereditary alpha tryptasemia with symptoms. And we have seen two important things that we have been able to measure, which is that those patients have, and this is a normal skin biopsy with all the small fibers here and the very nice meshes here. And the meshes are in disarray, and the fibers are gone in patients with hereditary alpha tryptasemia and MCAS who present symptoms of mast cell activation. And this is critically important to have this skin biopsy to be able to make the diagnosis. And you see here that also when we actually measure the cerebral blood flow, there is a decrease in the cerebral blood flow in hereditary alpha tryptasemia with symptoms and with the MCAS as compared to controls. So we have been doing an approach in which we are able to assess what is it happening in the patients from the neuropsychiatric standpoint by measuring their cerebral blood flow, also assessing their dysautonomia symptoms, and then being able to address the potential for a small fiber neuropathy with neuropathic pain. And because of that, the patients have been referred to neurology, to neuropsychiatry. It is very easy through a biopsy to rule in or out the potential as small fiber neuropathy, and then to make the kind of the link to, is this causing the pain? Is it the cause of the pain for those patients? So again, this is very hot from the press that we have been able to do that. Now, in personalized medicine, how do we target mediators and how do we target symptoms? Something important to address. So it has to be personal to patients, because patients go and Google mastocytosis or mast cell activation syndrome and they say, well, I cannot take any of the non-steroidal anti-inflammatory medications. And you are telling them that, in fact, that is not the truth, that if they tolerated aspirin, if they tolerated ibuprofen, if they tolerated naproxen before they got diagnosed, it's likely they will tolerate that now, and a challenge needs to be done. So only about 20 to 30% of the patients with, for example, mastocytosis are intolerant to non-steroidals. So the vast majority, 60%, do tolerate that. There are medications, for example, vancomycin and quinolones, that are more prone to activate mast cells. And in those medications, we try to avoid them for those patients. But we also try to avoid any medication that they have reacted in the past, and we are able to make a diagnosis. So patients can be allergic to penicillin, can be allergic to cephalosporins, can be allergic to also other things, such as environmental allergens and foods. So again, very personalized to the patient. The patient needs to have either a medallion bracelet or something that actually identifies the patient as whether she can take or cannot take at times where they need surgery, they need radiocontrast media, they need to be kind of in an emergency situation treated with some of those medications. We also have to identify what are their triggers and tell them to avoid them, whatever exercise. So not all exercises trigger same symptoms, like swimming is really well tolerated by most, if not all, MCAS and mast cell activation and mastocytosis patients, but running may not be for everybody. changes in temperature, but then heat might be good for some and cold might be good for other people. So very personalized. Pre-medications for surgery and for procedures, as I was mentioning, include H1 and H2 antihistamine blockers. And in some patients with already respiratory symptoms, we add a leukotriene blocker such as montelukast. And then steroids are reserved for patients who have already reacted or who have a high mast cell burden and they are going into for special procedures or major surgery. So for those patients, steroids will be added, but it's not something that we add for everybody. Then I think it's important that we add personalized things also for example, for patients who have an increase in their prostaglandins and have a lot of flushing and headaches. We have used aspirin very successfully in those patients up to 600 milligrams, 650 twice a day. And in those patients, like in patients with AARD, their symptoms, at least 70% of the patients do very well in that regime. So thinking about, all the potential other medications that you have here, the non-sedating antihistamines are the first line, the H2 blockers, and then sodium cromolyn is really something that we use a lot for the gastrointestinal symptoms, although it has to be taken 4 times a day, which patients don't really like. And then Cutaneous is also a mast cell activation blocker that has been successfully used. So again, you have here all the doses that have been used. Now, epinephrine is again personalized. We have to teach the patient how to use an EpiPen. We have to tell them every year to renew their EpiPens, and they have to know where the EpiPens are and how to handle them. And then we have to do a teaching session, I would say at least once a year, where we actually provide evidence on how that would be used and what are the symptoms, the throat tightening, the elephant in the chest, and then passing out this feeling of impending doom that the patient describes so well. So again, education on an EpiPen is not sufficient to just provide a prescription for the patient. We just have to do the extra step of the education. And if it's a kid or an adolescent, we have to make sure that the parents or whoever is going to be directly involved with the kid and the adolescent will hear that they always have to know, where is my EpiPen? Is my EpiPen not expire? And then how can I use it, and when can I use it? And again, other medications such as steroids and others will be important for some patients. Now, as I was mentioning at the beginning, Hymenoptera-induced anaphylaxis is a pretty severe, potentially lethal event in patients with high mast cell burden. And in patients also with idiopathic anaphylaxis or severe anaphylaxis in the kind of the setting of a mast cell activation disorder, particularly patients with hereditary alpha tryptasemia, omalizumab has been really a godsend to those patients. So from patients who are going to the emergency room once every month, once every 2 months, who are using 12 to 24 EpiPens a year, now under omalizumab, that has been reduced to practically 0, and the quality of life of those patients has dramatically improved. So we have used a lot of omalizumab under the chronic idiopathic urticaria, FDA indication at 300 milligrams every 28 days. There is a publication, I think, from the NIH that said that the significance was not quite reached, and in our experience here at the Brigham in Mastocytosis Center, we have lots of patients. We haven't published that yet. Lots of patients who actually have done extremely well under omalizumab. So I think that we need to do more. We need to do a good study, and we need to actually provide some numbers. But omalizumab is here to stay for those patients and cannot be replaced by steroids or by any other medication. So I think, and the sodium Cromoglycate is something that is old but very powerful. And you see here that it addresses skin symptoms, central nervous system, gastrointestinal symptoms. And you see that when the patient uses it, and this is a study done by my former mentor, Frank Austin, where the patient is its own control, and with the patient was on the medication, had no skin symptoms, no brain fog, and no gastrointestinal symptoms, no diarrhea. When the patient stopped doing it, the patient was its own control, the symptoms came back. So powerful medication for certain patients. And to finish, I just wanted to say that we are now in the molecular area, that we have what we call tyrosine kinase inhibitors. There are some already FDA approved. We were very happy to participate in the pioneer study that approved avapritinib, and then we are participating as many other centers in other tyrosine kinase inhibitors that are the next generation. And what we have seen, and it's already been published by our group and other groups, is that using a tyrosine kinase inhibitor such as avapritinib addresses the mutation per se and is capable of not only limiting and decreasing the amount of mast cell burden that the patients have, but also the symptoms. So in patients who had flushing, itching, abdominal bloating, pain, brain fog, avapritinib at 25 milligrams, which is a dose that is now FDA approved, has been able to tremendously help those patients, and has also, and it's in the process of being studied, reduced the amount of medication that the patients need to take, because some of the patients need to take quite a bit of medications, and avapritinib can actually reduce that. And for full disclosures, I'm a PI on blueprint studies, so this is part of my clinical trials results. We don't, if for advanced systemic mastocytosis, for example, those tyrosine kinases have not done the job that we expected. And so for advanced disease, the prognosis of the patients continues not to be good. Patients who have advanced mastocytosis are expected to live about 2 years or a little bit more, but no more than that. And their prognosis is similar to any hematological disease. So again, unexpectedly, tyrosine kinase inhibitors are actually helping patients who have mild disease, who have chronic symptoms, who may have also associated acute symptoms, but have prolonged life. And what it's doing, it's improving the quality of life of those patients. So that, and one of the things that I have not mentioned to you is that those patients have also have the skin lesions, the cutaneous lesions, lighten and almost disappear on the new tyrosine kinase. And this is, potential side effects of the the brain hemorrhage, the thrombocytopenia for the initial avapritinib, but is being kind of in the next generation, so there's no brain kind of the penetration for the new drugs. So I think that to finish, I just wanted to mention that mast cell activation syndromes, we just have to know how to place the diagnosis and what to do. We have to address the comorbidities. We have to use our diagnostic toolkit, the KID mutations, the genotyping, and we have also to see if patients are candidates for, I call it new therapy, but some of them are now FDA approved. Is our patient a candidate for a tyrosine kinase inhibitor? I think this is a question that has to happen early and not late in the conversation. And then using inhibitors of monoclonals that inhibit KIT or inhibit IgE or inhibit other cytokines, like for asthma treatment or for nasal polyposis for others, is also coming our way for mast cell activation disorders. So this is our center, and you're always welcome. And Dr. Frank Austin just passed at age 95, and we are missing him. He was the inspiration for our center. He worked 40 years on patients with mast cell activation, and he was one of the first ones who said that patients will come to our clinic that will present with symptoms of mast cell activation, but will not have mastocytosis. And I heard that from him very early when I came to start my fellowship in 1991, and I did not understand what he was mentioning. And the field exploded about 15 years into my tenure at the Brigham. So thank you so much for listening, and I'll be happy to entertain any questions.